What is your EMG workup when a patient is suspected of having a neuromuscular junction disease?
For us, it is first a clinical checkup, and then for the neurophysiology, we start with repetitive nerve stimulation if we think it's a neuromuscular disorder. We take mainly proximal muscles, where we go from anconeus, often, usually deltoid, trapezius, and marsalis. For an ordinary myasthenia, it's more or less waste of time to go to distal muscles. Then we go to single fiber EMG. Also, if the repetitive nerve stimulation has been abnormal, but the other way around, if the repetitive nerve stimulation has been normal, we definitely take single fiber EMG. And then we may start in the an arm muscle, extensor digitorum communis, easy to activate, and often involved in both ocular and generalized myasthenia. And then we go to one or two patient muscles.
We would follow pretty much the same general approach, though it would vary considerably depending upon the clinical findings in the individual patient. For example, in a patient who had significant weakness of limb muscles, and we were trying to determine if it was myasthenia, we would start with repetitive stimulation, and we would usually start with a hand muscle and then move to a shoulder muscle, and then go to single fiber EMG. We don't do much repetitive stimulation in the face. For a patient who had ocular weakness predominantly, or very mild generalized symptoms, then we might very well start with single fiber EMG, recognizing that repetitive nerve stimulation is frequently, if not usually, normal in such patients, in the limb muscles, that is. And then we would do single fiber EMG, and we would usually select the muscle to test first with single fiber EMG based on the clinical findings. And the muscle that we would usually use in such a patient with very mild weakness would probably be the frontalis, sometimes the orbicularis oculi.
We would follow a rather similar approach, but I must say that it depends on the presentation of symptoms. In a patient with predominantly ocular symptoms, we very often go directly to single fiber EMG without even previously doing repetitive nerve stimulation study, or we do it in the face. In a patient with bulbar symptoms, we also go to one of the facial muscles, and it is most often the orbicularis oculi muscle, for which we know that is very sensitive to show early changes. We use stimulation jitter studies in practically all of these patients. And we have extensive normal material for this muscle. If the patient presents with predominantly extremity fatigability, then we go to either deltoid, which is, to our experience, quite good and sensitive, or to EDC. And when we are asked to do a single fiber EMG study in an infant to evaluate him or her for possible childhood myasthenia or any neuromuscular transmission disorder, such a patient will always have repetitive stimulation first. And then we do a stimulation as a EMG study in the child, infant or whatever, without any sedatives, because in our experience, the child will become very quickly cooperative or quiet at least. We do not need much patient cooperation with stimulation jitter studies. And we usually select the tibialis anterior muscle. We use emlacrine before, and this is the only thing that we use to reduce the discomfort. The child is allowed to sit in his mother's lap, and we have no problems doing the full study in these situations.
I can make a couple of observations based on our experience with doing single fiber EMG in a large number of patients with myasthenia. This might help in deciding the approach in individual patients. As I mentioned earlier, and as I think Yosha just confirmed, patients who have purely ocular symptoms are unlikely to have a decremental response to repetitive nerve stimulation in the limb muscles. And so doing such studies in patients like that will not be very rewarding. So in those patients, as we both mentioned, we would usually start with a facial muscle. In patients who have bulbar symptoms, any difficulty chewing or swallowing is a manifestation of myasthenia. Almost all such patients we have found will have abnormal jitter in the EDC. So in such patients, particularly if their symptoms are more than just minimal, it would be reasonable to start in the EDC. However, in patients who have MuSK myasthenic, who have antibodies to MuSK, it is quite common to find normal jitter in limb muscles when the symptoms predominate in the facial or bulbar muscles. So in that subset of patients, it would be wise, if you knew what you were dealing with or suspected what you were dealing with, to start with a facial muscle. But a point to emphasize about patients with any form of myasthenia or any degree of weakness is that unless you test a muscle that is clinically weak, you may not find abnormal jitter. So when you're planning a study in a patient, and it's reasonable to do so, if you start with a muscle that has weakness and you do not find increased jitter, then you're unlikely to be dealing with myasthenia.
I'd like to add two things. One about the MuSK myasthenia. They are often very focal. You can have on one side a rather severe degree of abnormality, but not on the other side. So I really agree with you to go to the side of the symptoms. And in this patient, we should also not forget to look at the neck muscles and perhaps also the masseter muscle. And regarding the decrement, one can say if we now find abnormality in single fiber EMG, which we happen to start with in that day, should we then do the decrement at all? Well, these two things give us slightly different information. The decrement not only is the decay in amplitude, it also shows the initial amplitude. That means how many motor M plates are there from beginning without fatigue. How many can we facilitate with the activation? And the other thing, are there any extra phenomena? Do we see extra discharges as a sign of specific myasthenic situation, congenital, for example, slow channel syndromes, or overtreatment, or cholinergic crisis, and so on. So decrement is also a very good thing. They really complement each other if we look at decrement in that way.